There's a moment that happens in exam rooms that we don't really talk about. A patient sits down, a physician walks in, and in that moment, a decision is made. In medicine, we like to believe that diagnosis is objective, that our symptoms paint a picture, that our bodies tell a story. A patch of dry, irritated skin that could suggest eczema, a butterfly shaped rash across the face could suggest lupus, a mole on the bottom of your foot could be melanoma. The point I'm trying to emphasize here is that this is the medical training system, a system built on pattern recognition, standardized images, clinical frameworks that shape how your physician deduces the diagnosis. But there's a quiet limitation in that training where it doesn't just teach what to look for, it simultaneously shapes whose conditions are recognized and whose go overlooked. And don't get me wrong, medicine is incredible. We're able to map the human genome. We're able to treat conditions that were once fatal. We now know more about the human body than fathomable decades ago. But even with all that advancement, there are still gaps. Not necessarily in what we know about the body, but more so in how we understand a person. People carry histories, people carry experiences that shape how disease presents, how it persists, and whether it's even recognized at all. Because people are more than bodies. People carry histories. People carry experiences that shape how disease presents, how it persists, and whether it's even recognized at all. And when those human contexts go ignored, diagnosis can fail, even if the science indicates otherwise. If you open up a dermatology textbook, you're likely to see an abundance of rashes, lesions, melanomas, and other dermatological conditions. And what you'll come to notice in these medical training academic materials is that the skin tones depicted in these images is light, very light. And I mean, that can be helpful unless, of course, you're the patient that doesn't look like the textbook. And this directly impacts the way medicine is taught. Researchers analyzed over 15,000 clinical images to understand what skin tones were represented in dermatology, and the results were striking. Only about 11 to 18% of those images depicted darker skin tones. Let me show you what that looks like. You see a population of people on the screen. This is what about 11 to 18% of that looks like. In the grand scheme of the study, that's less than 1 in 5 images. That's like ordering an extra, extra, extra large pepperoni pizza and only receiving about 1 to 2 pepperonis. And you may be wondering, Leilani, why do I care about how many pepperonis are on my pizza or about how many dark skin tones are depicted in a textbook I don't have? And to that I say, dermatology is the study of skin, hair, and nails. It relies heavily on pattern recognition, and it's a very visual specialty. Diagnosis depends on seeing something enough times to know what it is. So when an abundance of academic training materials in the curriculum reflects one demographic, you can imagine gaps emerge and limit healthcare for a lot of people. Research shows that Black patients are diagnosed with melanoma at significantly lower rates than white patients. And while that may be true, when they are diagnosed, it's more likely to be at a more advanced stage of the disease. In fact, Black patients are 2 times more likely to present with regional or distant melanoma, while white patients are likely diagnosed when the condition is more localized and highly treatable. So when we step back and when we zoom out, although melanoma is about 25 times less prevalent in Black populations, it's still a major cause for concern because of the delay in diagnosis. So that indicates to me that biology is not the only thing to be considered here. There's access, awareness, what both patients and clinicians are able to recognize. A study found that only 29% of their dark-skinned participants knew that they had any type of skin cancer. Only 5% of those participants had ever had a full-body head-to-toe skin exam. And so I say that to say, in real life, this looks like people navigating very complicated, very serious conditions without knowing what to look for, what questions to ask, or that they should even be looking at anything at all. And it's not just about when melanoma is diagnosed. We also need to consider what it looks like and where it appears. Research shows that the most common manifestation of melanoma in white patients is called superficial spreading melanoma. This appears in areas of sun exposure, like the arms, back, the legs, anywhere extensively exposed to ultraviolet radiation. Whereas in Black patients, the most common manifestation of melanoma is called acral lentiginous melanoma. And this presents in areas like the palms of your hands, the soles of your feet, and your nail beds. As a matter of fact, acral lentiginous melanoma only accounts for about 1 to 7% of melanoma manifestations in white people. And if you look at the charts underneath the image depictions, you can see that inverse relationship where what's common in one demographic barely exists in the other. And so when clinicians only recognize one pattern on one demographic and one set area of locations, then again, humongous gaps emerge. Not just gaps in knowledge, but gaps in care. So if we step back and think about this, again, dermatology is one of the most visual specialties in medicine. Doctors are trained to recognize patterns and deduce diagnoses. So if 1 plus 1 is 2, when medical training and medical education centers one demographic academically, that limits care for an abundance of people. And when pattern recognition fails, diagnosis goes out the window with it. And that's why cultural competence in medicine is so important. Not just as a buzzword or a checkbox on medical school applications, but as a diagnostic tool. When a patient is understood, encompassing their background, their culture, their environment, their lived experiences, clinicians can ask better questions, and better questions yield better diagnoses. And just like that, medicine is more accurate, but even more humane. I got accepted into UC Davis as a molecular and medical microbiology major. In that field, I learned about biological systems, how they function, how diseases spread, how cells respond, how they reproduce. But that didn't feel quite right for me. I felt extremely distanced from the factors that influence who gets diagnosed, when they're diagnosed, their treatment, and so on. And so switching into African American and African studies didn't take me away from medicine, it just gave me a new lens. As I began to study more seriously, I began to ask questions in my coursework and through my research with my family and my community across generations about how they care for their skin, what their experiences in healthcare look like. And the themes I continued to encounter were mistrust, misinformation, discomfort in clinical settings, and social hurdles that prevented them from seeking a physician until something got way too severe. And so, when we reduce people down to symptoms, not only is it quite dehumanizing, but it's very easy to neglect the bigger picture. So I'm going to spell it out. Culture Culture shapes health behaviors. Social context shapes access to care. History shapes trust in medical institutions. And identity ties it all together. So no, this isn't just about biology. Because treating a disease is biochemical. Treating a patient is human. Thank you for coming to my TED Talk.